Hey guys, so this is part 2 of the video I did yesterday using the PulmoVista. The patient yesterday was on APRV with a P high initially of 34. I put the PulmoVista on and started weaning the P high. We went down 33 and then 32, and we guided this weaning process with the PulmoVista, which uses, again, electrical impedance tomography. So it's a pretty simple principle. There's electrodes 16 around the chest, and they send vectors across. When there's a lot of air in the lung, it impedes the current traveling across more, and as the lung expires, there's less air, and that impedes it less because the current can easily travel across. Okay. Sorry about that. All right, so yeah, as I was saying, the electrical impedance is basically, you could say, it's a surrogate for understanding where tidal volume is, where volume is. If you have an increase in impedance, this number is positive here, then you are understanding that there is more volume being distributed to these regions. So yesterday we brought the patient down to 32 of a P high on the APRV mode, and today I tested my luck going down from 32 just to 31. So I'm going to show you the trend over time, and we have here the reference that is at 12:13, and we're going to compare over 2 hours. So again, my assumption is I want to make sure that the P high level is not too high, where we're reaching on the pressure volume loop to a less compliant area. As you know, just typically we use global values on the vent, and we'll be, let's say, on pressure control we have a volume of 350. We go up in the units and we see that there's no great increase in tidal volume. We can assume that we're just adding more pressure with no distension, no improvement in tidal volume. So this is more scientific. It's actually giving you real-time data, and you're not just looking at the global values. We are looking at regional distribution of ventilation using the PulmoVista. So I'm going to use the scroller and I'm going to go across. Don't forget that up here it just means globally. It adds up. So all of these areas in the ventral to dorsal region down here, they'll add it up. So the global, doesn't say where it's regional. So we see that something great is happening here. We've reduced, again, the pressure. We've reduced the amount of pressure within the lung, and we're actually getting more impedance. Therefore, we're getting better volume. With which again can we can assume probably that again we did a good move, that we're bringing it down and we're bringing that lung into a more compliant area in the pressure volume loop. So we want to look over here at especially the dorsal regions, the mid dorsal regions. So over time, let's just look at the trending. This is telling you that whatever you did, you are recruiting lung in this region, and that region. Okay, minimal at the ventral region. And now I'm going to use the scroller after pressing the control. And this shows the trend. So we got kind of like this trend that we can see. This will show, this is a color-coded method, which will also show the regional distribution. So let's say region 3, for example, okay? Region 3, comparing this to this, as we scroll across, you're going to see in region 3 probably blue appearing here. And this applies also for the dorsal region that we're seeing here, right here. So obviously we're increasing the amount of volume in the dorsal region. That's excellent, and we're doing this again not by increasing the pressure. We're doing this by decreasing. Therefore, we're going to expect also eventually as we scroll some blue in this region, and also probably some eventually on region 2. Okay, sorry, it's hard to talk film and point. Okay, so let's go, guys. Let's look at first the regional distribution. Don't forget that it's going to show wherever the blue is appearing, it's saying compared to the reference, there's more volume being distributed to that region. If we see an orange, then we're saying that compared to the reference, there's less volume. Okay? Now, don't forget, blue doesn't necessarily, even if it means gain, it doesn't necessarily mean that that blue is always good and orange is always bad. Remember, so you know, if I'm making a change, let's say I would, for example, try and go up on the P high, and all of a sudden, after you know an hour or so, I look and that P high only created blue on here. Then I know that I haven't recruited anything, and I'm just going and ventilating the ventral areas, which is not a good idea, right? So let's do this. Okay, color code. All right. Okay. Okay, so here, this is good. So we decreased, right, the P high, and we're losing volume here in the higher ventral regions. So that is this could be indicative of the previous setting was creating a loss of compliance. So that's a good move. What I want to see is orange here and blue starting. That means that you're losing distribution compared to the reference and it's being transferred down here. So that's a sign of recruitment. Right. Oops, sorry. Let's check this out. All right. See, now over time, and that's what shows it, like how long it takes to recruit, you know. Sometimes we'll do optimal PEEP at the bedside and we're literally like letting a minute or two go by. That, you know, it can take a very long time, understanding that the lung is not homogeneous, it's heterogeneous, and that alveoli have a great variation sometimes in time constants, meaning some of them will increase at different pressures, some of them will open up, some of them will never open up, and some of them will open up rapidly and some over a long period of time. And this could be minutes to hours sometimes. And this is how APRV often, we have to wait about 8 hours to kind of make an assessment often. Sometimes there's no improvement. All of a sudden, by 6 to 8 hours towards the end of your shift, you're seeing drastic improvements. Not all the time, but if the potential of recruitment is there, you know, it sometimes takes hours. All right. So we see here always good stuff happening. Blue at the bases. This is indicative of recruitment. Okay, and this is where we are now. So this is really good. You know, this is textbook what you wish will happen all the time. Less pressure, improved volume. Okay, and this is increased impedance. So we see the color code that gives us the information. Then we can also just quickly see without having to scroll and look at this one. We can just see like, oh yeah, this is happening. If we're increasing or decreasing and things are flat, or God forbid things are going downwards, then you're de-recruiting. Quite simply, just to keep on repeating, the more the current on the tomography machine is impeded, is indicative of more volume in that area. So we can see over here that after 2 hours we have gained some impedance and a significant amount, exactly where we want it at the dorsal base. Okay, let me just refresh. You press the button down here and you refresh it. Just a minute. It takes a little bit of time. It's refreshing trend data. Okay, now the previous reference that I had put was when I had 32 and I went to 31. So the reference was looking at what happened when I dropped from 31, from 32 to 31. I saw such a great result, so now I went and pressed 31 as a reference, and I'm going to see if that 31 is increasing is continuing to have improvements. So sorry for the wiggling. Let's bring that over here. Let's do the color a little bit more rapidly now that we understand. This lady is continually recruiting. Holy smokes. Wow. Okay, sorry, I'm really impressed. When I get giddy, you know good stuff's happening in the lung. There you go. Wow. A total 3.65 in impedance. A little bit more here, but we're still gaining. So not only did we gain from 32 to 31, 31 over time is still improving the lung. And that makes quite sense. It makes good sense, because if you looked at part 1, the tidal volume was pretty much about there, but we had a P high at 34. Now, we wouldn't be able to wean the P high that quickly within not even 24 hours, but we're confident to do that, and we're confident we're not running into trouble. The patient has the same tidal volume with plateaus that are almost getting within safe regions. We weren't too worried about the 34 initially when we first put this, and this patient's been on it for quite a long time, the 34. Don't forget, in part 1 we spoke about it being a patient with morbid obesity, and definitely a long-term ventilated patient. She's lost a lot of weight over the last 4 weeks. So it just makes sense that I was confident to put it at 34 initially, because I knew that there was a lot of pressure from the weight, pushing down on the lung. So I wasn't worried that the 34 was all being distributed to the inside of the lung. I knew that there was also a lot of pressure pushing down on the chest from the obesity. Lost a lot of weight. The X-ray, to be honest, is not that significantly different. As you know, with COVID, if you're treating COVID patients for over the last year, unfortunately, once they're ventilated, they don't necessarily do that well, unfortunately. Okay, so let's just get back and stop ranting about other stuff. Okay, so this is pretty much part 2. Yeah, okay, that's all I had to say, guys. Okay, if there's any significant or really awesome examples of the PulmoVista and good teaching material on this specific case, I'll make another video. I don't know how many parts there are. Maybe this is the last part, or maybe there'll be more. Okay, thanks, guys. Bye.